Dear Chairman, thank you for this invitation to join and to present at EBC 2020 Live. This is really my great privilege to present this case entitled String Technique to Overcome Severe Protrusion, the Role of OCT Guidance. This case was prepared with the collaboration of Dr. Schwob from Paris, France. So this case is about a 20-year-old woman who was scheduled for complementary revascularization on the prox and mid LAD following a non-STMI. The acute coronary syndrome was related to a first marginal branch occlusion. This revascularization strategy was decided by the heart team despite the presence of a diabetes. The circumflex and marginal bifurcation lesion was treated by a TAP strategy using 2 synergy stents 4 days before. This is the initial angio. You see that the result on the first bifurcation here is okay, and we observe this very long diffuse disease on prox and mid LAD, and also a subocclusion of the first diagonal branch. We first performed a distal LAD FFR to assess the ischemia or the significance of this lesion, and you see that the distal FFR was 0.7. So we decided to apply our plan, which was prox, mid LAD, and first diagonal branch. We initially performed the pre-PCI OCT on the LAD, and you see that there is a very diffuse, quite aggressive atherosclerosis with presence of lipids, inflammatory cells, and very, very diffuse disease. Finally, we're able to identify here a decent, not great, but decent landing zone. You see here with a EL to EL diameter measured at up to 2.75. Here there was the MLA was 2.2 square millimeter, but the left main dimensions were huge, with a maximal luminal diameter measured at 6.4 and a minimal 4.5. So the complete length of the lesion was measured to 48 millimeters from the ostium to the distal, to the landing zone. So what was the strategy? We had a severe LAD atherosclerotic infiltration. We've got an inflammatory vulnerable plaque because of these macrophages infiltration, this large lipid pool. The LAD and left main diameters have marked discrepancies, and this is a trifurcation. So based on that, we decided to first fix the first diagonal branch and then perform ostial LAD to mid LAD PCI without involving the left main and using 2 stents. So we started with a proximal to mid LAD pridilation, followed by the implantation of a 2.5 per 16 synergy everolimus eluting stent on the first diagonal branch, and followed by the implantation of a 3.5 per 32 synergy Megatron stent without any pacing on the LAD wire. And unfortunately, when we inflated, the patient took a deep inspiration, and we observed this huge, as a result, there was this huge excessive stent protrusion in the distal left main that it can be nicely visualized on the angio. So the question was now how to fix. And then we had memories of this article by Gabor Thot and colleagues about the string technique that was previously presented at the EBC. So that's where my previous meetings at the EBC were extremely useful for me. And although it is not one stent strategy, we decided to apply that to fix this protrusion. So we first performed the a side branch wiring with across the first cell using a cyan blue, and try to pot the first crown with a 5.5 non-compliant balloon. We use a 5.5 per 12 because we got no shorter balloon, and decided to then perform a subsequent kissing balloon inflation in ostial. We put the wire in a better position in the circumflex, and then perform this kissing using a 3.5 and 3.0 balloon. We were pretty pleased with this result and decided to finalize our procedure by implanting a 2.75 per 16 synergy eluting stent from prox to middle AD. We then doing a 3.5 per 8 pot, and finally decide to go for OCT analysis from circumflex to left main. And actually, we were surprised, but it was not a good surprise, and observed a major malapposition in the ostial circumflex and in the left main, as you can see here. That was actually a huge malapposition from with a distance between the struts and the vessel wall over 1 millimeter. So that was not good, and that was not something that could be tolerated. The good point was that we did not observe any dissection on the proximal part of the left main, and the 3D reconstruction confirmed that the wiring was adequate, but there was a poor cell overexpansion and major malapposition. So we decided to keep our wire in the same position and go for larger balloons kissing inflation. So we use a 4.5 and 4.0 compliant balloons in LAD and circumflex, respectively. That was the final angio, and of course we decided to go for both branch OCT analysis to confirm our feelings and our intuition. So this is the LAD to left main OCT analysis, and you see that the result on this OCT run is really great. There is no malapposition, no poor or poor expansion in the LAD. This is the carina, and you see that the cells are in an adequate position, and there was no dissection on the ostial, on the mid and ostial left main. The 3D reconstruction also showed a very nice wire position in the first cell of the stent. We can see the differences in the stent final diameter along the LAD and the left main. And from circumflex to left main, we also observed a better result, and you see that the malapposition was extremely reduced, and now we only have a short portion of the stent with that is malapose with a distance between struts and vessel wall below 0.4, which is acceptable according to the EAPCI guidelines. This is the final angio view. We're pretty pleased by the result. We decided to go for a double antiplatelet strategy, mixing aspirin and prasugrel for at least 12 months. Probably that we will go over 12 months in this situation because there is a high ischemic risk and the patient also has a low bleeding risk. So to summarize, ostial LAD lesion treatment is still challenging because treating the distal left main should always be considered rather than turning bifurcation PCI down and only nail the LAD. I think that using the Megatron was also a good option because it has really nice overexpansion capacities that really help us in this case. The string technique remains an option to fix inappropriate protrusion in the polygon of confluence. And of course, in this case, the OCT guidance is a very, very valuable addition to help us. I thank you for your attention.